Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is cataract surgery in patients with low endothelial cell count, with specific importance on the specular microscope. Endothelial cells layer is basically the innermost layer of the cornea, responsible for maintaining the transparency. It is basically responsible to pump out all the fluids and so that it remains transparent. Its size is 5 micrometer, the cells, and the total layer is 20 micrometer in thickness. The endothelial cells in infants are almost 3000 per square millimeter, but with the passage of time, they keep on decreasing until 60 years of age. They come up to, in old age, up to 2000 per square millimeter. So if we make a calculation, it makes about almost 0.6% loss every year. The thing about these cells are that these cells cannot regenerate. Once they are damaged, the other cells enlarge and try to replace that area, but regeneration in these cells is not possible. As I told you earlier, this presentation is about the phaco or cataract surgery in low endothelial cell count patients. So what happens is that when we do cataract surgery, whether we go for phacoemulsification, we do extracapsular cataract extraction, or even manual small incision cataract extraction, endothelial cells come under stress, and there is documented loss of the cells. It happens while we are doing it, insertion of any manipulation. We are putting gel, we are putting phacoprobe. It depends upon the insertion of IOL, and it also depends about our phaco time and the energy which has been used over there. All these things plus the skills of the surgeon, all these things contribute to the endothelial cells loss during cataract surgery. It has been documented that in phacoemulsification, the cells loss can be from 4.7%, and in some cases it goes up to 16%. While if we talk about manual small incision cataract surgery, the loss is almost 15.83%, which is also comparable the results in even extracapsular cataract extraction. So this point is very important, that when we are doing surgery in low endothelial cell count patients, for example, the cornea is already sick or damaged because of any endothelial or any corneal endothelial dystrophy or any corneal degeneration, already trauma or anything, we have to keep this point in our consideration, that while doing this surgery, we are going to encounter this problem. As I talked earlier, there are many predisposition and disposing factors which can contribute it. For example, uveitis, inflamed eye, already there are KP cells and inflammation going on. They put a stress on the corneal endothelium. Pseudoexfoliation, glaucoma, high pressure, it also causes decreased in endothelial cell count. Then we talk about trauma, we talked about dystrophies, and even when put a new grafts, for example, PKP or DZAC, these all the cells while doing surgeries undergo definitely some corneal endothelial cells. And these cells are extremely important for the health of the cornea. So as I mentioned earlier, the endothelial cell loss depends upon many factors. So how it can be prevented? It can be prevented by taking precautionary measures, and one of the precautionary measures is to use proper viscoelastics. Viscoelastics can be dispersive viscoelastics, which basically act as a coating, which coat the endothelial cells. The dispersive viscoelastics example we can give like honey. They get dispersed, they coat, and they protect the heat generated, the energy generated during the surgery to damage those fragile cells which will not regenerate again. So dispersive, different companies, different brands are producing, which should be used if we are encountering a patient with low endothelial cell count, and even in the normal patient, this should be used properly to coat it and protect those layers. While cohesive viscoelastics, the examples usually is given like a jam, which stays over there, which fills up the capsular bag, which maintains the anterior chamber. So capsulorhexis can be done easily, comfortably, and IOL insertion is not problematic. So that maintains over there. But the problem is that the dispersive, which I talked earlier, they are protecting the endothelium, but they are usually difficult to remove because they are dispersed. While this cohesive, for example, if I take Provisc or Helon, they actually come like a bolus. So they are relatively easy to remove, but these both should be used in a cataract surgery, whether you are using whatever, phaco, extra cap, or small incision. Because ultimately we have to protect the eye of the patient, the endothelium of the patient. Now I come towards the importance of specular microscopy. Specular microscopy to do with endothelial cell count, usually it is done in post-PKP patients, DZAC, DMAC, any corneal dystrophies, these things. But it is our routine practice to do specular microscopy and to do endothelial cell count in all patients undergoing cataract surgery. This gives the surgeon the exact idea about the health of the cornea. So when we do this endothelial cell count, two parameters which are very important to see. One is the coefficient of variation. If it is between 0.20 to 0.30, cornea is healthy. But if it increases, it goes towards 0.40, so that is not very healthy cornea. The second point which we consider, apart from the cell density which I talked earlier, that is usually in old age patients we encounter almost 1500 per square millimeter to 2000 per square millimeter, sometimes 1000. The second parameter which is very important is the percentage of the hexagonal cells. We know that these cells, the endothelial cells, are hexagonal cells. Because of their hexagonal pattern, their surface area is increased. So they should be more than 60%. If these hexagonal cells in the specular microscopy are less than 60% and coefficient variation is more than 30%, going towards 35, the decision making should be very careful. Proper use of these viscoelastics I told you earlier, and the selection of the surgeon. These patients need expert hands who can manage in minimum phaco time and minimum phaco energy, who can deliver the results. I told you earlier that if the endothelial cell density is between 1000 to 1500, surgery can be done, but the critical value is 750, and some people in literature have documented 500. So if the cell loss is that much, that in 1 square millimeter you are having 750 cells, then the chances of decompensation of the cornea, if not early, maybe later on, are quite high. So these things should be kept in mind. This is specular microscopy. We have done the endothelial cell count. You can see here the different parameters. It is very healthy cornea with the central dense corneal density. Density is almost 2455, and coefficient of variation is 31. Hexagonal cells are 62%. I mean 60 to 70% is okay. You are not going to get 100% because the eye throughout the life is under too many stresses, and these gradually decrease. But between 60 to 70% coefficient, this hexagonal cell percentage is healthy one. So these two things are very good in this. I have shown you the slide. The other eye of the patient, here also you can see the cell density 2578, and coefficient variation is 32, more than 30%, 30, but it's okay. And hexagonal cells are almost 60%, I mean 57. So this is also considered a healthy cornea. Now this is endothelial cell count of a sick cornea. You can see here, you are not going to see the typical hexagonal mosaic pattern over there. You can't see. But if you concentrate on the photograph of endothelium, you can see some areas where there are the cells, and in between there are gray areas. So this area, this endothelium cell, eye has lost a lot of endothelium over there, has been lost. So even you see the central corneal thickness now has gone up to 563, and we were unable to do any calculation about cell density, about hexagonal cells, about coefficient of variation. So this slide I wanted to share with you to show the significance of the specular microscopy. If we don't consider this, the eye is healthy, the cornea is still transparent, and if we go this patient with phacosurgery, without the precautionary measures, without the use of cohesive and dispersive viscoelastics separately, and the phaco time and energy is enhanced, this eye, which apparently looks normal, no edema, will later on go into corneal decompensation and edema, maybe in 1 year, maybe in more than 1 year. So this I wanted to share with you to show the importance of specular microscopy. This is the second eye of the same patient. But here you can see the corneal thickness, central is 535, cell density 1592, and coefficient of variation is 22, and hexagonal cells are 59%. So this eye is relatively healthy eye as compared to the other one. Because of the aging, the cells have definitely decreased, come up to 1500. These also need a lot of care to be done, surgery, but it is a relatively healthy eye from the other eye. So this whole discussion was to show up the importance of specular microscopy. I know these things add to the ultimate cost of the surgery and things, but if you consider in a broad prospect, you will see that the decision making and the later on complications can be anticipated earlier if we do these tests before the surgery. Well, it is our routine practice to do it all patients, endothelial cell count documented and everything. So this was the point I wanted to discuss with my respected audience today about the management of cataract surgery in low endothelial cell count and the importance of specular microscopy in cataract surgery. Thank you.